Good afternoon, everybody. Thank you very much for joining us at CEIH for our very first Improvement Showcase, our first series, Improving Flow. So we would firstly like to start today by acknowledging that the traditional land that we're meeting on here in Adelaide is the land of the Kaurna people, and that we respect their spiritual relationship with their country and their relationship with their country. But we'd also like to acknowledge that many of you are sitting on lands of other nations, and that we also pay our respects to those lands. We acknowledge the traditional people as the custodians of the Greater Adelaide region, or from the regions that you may be sitting in today, and really recognise that the cultural and heritage beliefs are still as important today to the people living in these areas, and to the people who are from these areas as well. So before we get started, just a quick bit of housekeeping. We just wanted to let you know that this session is being recorded, and that the intention is that the session will be shared with people who have registered but might not have been able to attend. But the actual presentation that Angie gives us today will be edited from that and shared more broadly, which is we're really grateful to her for letting us do that. Before I hand over to our first speaker, I just want to quickly go through and give a little bit of context about the CEIH and who we are. The CEIH was established as an independent government agency on the 6th of January last year. Pretty soon we're going to have to stop saying we're new, but because of the COVID year, I guess we're still feeling pretty new. And really, to give you an overview, what we want is excellent health outcomes, excellent experiences for everyone, and consumers, carers, clinicians engaged in design and delivery of evaluation of health services. We want increased confidence and pride in what is really a fantastic South Australian health system, a culture in the health system of striving for innovation and striving for excellence, and ultimately to have South Australia recognised as an excellent health system and a leader in healthcare innovation. And I guess to do that, what we do is we build capability. We create opportunities for people to learn new skills and support the mindsets that allow innovation to happen. We provide advice and support. We provide advice on collaboration and engagement, data and analytics, improvement science, health science, design, research translation, health scanning, as horizon scanning and innovation. But really an important message in there is that we actually don't know everything. What we do is we work to partner and connect. So it might be that we don't have the answers, but absolutely we see it as our role to partner and bring people together. And this means that as we connect people, clinicians and consumers across the system and across the community, they can collaborate and learn from each other. And so innovation and excellence in best practice is the opportunity to think big and look for creative solutions that place South Australia as a global health leader. And so that's why we're here today. We're here today really, to take the opportunity to put some of these things into action for South Australians and for, at this stage, people working within our system. This session has been offered really broadly to other people, but really, I guess what we're saying here is, that this guy shouted about some new invention and then it hit him. So, we kind of missed that and we didn't know that it happened. So I know that anybody can Google these cartoons, but this one's near and dear to me. The other thing, I guess the other reason that we're here today is really about this, right? So it seems like the right hand doesn't know what the left hand is doing. This is not a big state. We are not that big a place. And we're all pretty good people, pretty easy to talk to. But we have built some silos, and we have built in some areas, some competitive culture potentially, or maybe just a culture of heads down, bums up, let's fix our own problem. But absolutely, there is some similarities between the problems that we're trying to solve and some fantastic opportunities for us to collaborate in that space and learn from each other. And really, I guess, just in terms of thinking differently, what else could we be doing with the wheel, right? I much prefer the bottom option in this cartoon. So what if the big idea was connecting all the small ideas? What if bringing you all together here today is really about how we can connect all of those small ideas to bring them together and really see an impact for everybody? So the CEIH Improvement Showcase is not the be all and end all. This is just one thing that we'd like to kick off and continue to roll. We want this to stay simple. So keeping it simple is a really important message for us. Thursdays at 1, online whenever is really the principle that we were working to. Bringing healthcare teams together, but also bringing clinicians to that table as well. And I'm aware that we've got quite a few consumers joining us in the virtual room today. Providing a space to explore what others have learned is really what we're all about here. And other than that, there's not a lot of rules. So as we go through, we expect that this first series and then subsequent series will evolve. So series 1 on that note is improving flow, and I guess we had to come up with the first idea for a series, and what better theme in healthcare in South Australia at the moment, other than COVID, than understanding and improving flow. And so really what we're looking to do is to look at different ways that people have addressed flow across the system. So our first presenter, as I've already mentioned, is Angie Goodrich, who is the Director of Continuous Improvement Programs at SALHN in Southern Adelaide Local Health Network. We've got the team from Mobbery joining us to talk about ambulatory gynecology next week, supporting quality assertive discharge from Flinders Medical Centre on the following Thursday, and then the amputee prehabilitation program, which has currently been established at the Queen Elizabeth Hospital the following week. So without further ado, I'll just give you a quick idea about the way that we're going to be working today. So as I said earlier, if you can keep your mics on mute for the time being and just really give Angie the floor. If there's a really burning question that just won't make sense if you wait to ask it, I'm sure Angie will be happy for you to jump in with a passionate question. But other than that, absolutely fantastic if you want to use the chat function in Zoom to pop your questions in, and then we can sort of curate the conversation at the end. What we're looking for is about 20 minutes of Angie telling us the story, and then we're allowing time for people to have that collaboration and start to really talk to each other in the immediate space after that presentation. So without further ado, I will try to really slickly unshare my screen and let Angie share hers.
Thanks, Katie. Let's see if this works. I'm not actually on my computer. Here we go. And I've got Jane Basham, one of our improvement coaches, next to me, which is a very big help. So let me just, here we go. Can everyone see that okay?
Perfect.
Perfect. Okay. Great. Well, thank you very much for having me to speak today. And as I just said earlier, I've got Jane Basham, one of our improvement coaches, next to me, the sensei of improvement down here at SALHN. And Jane will be contributing a little bit as we go along to the presentation. So I also just wanted to acknowledge that the Kaurna people and pay my respects to elders past, present and future, and recognise and respect their cultural heritage, beliefs and relationship with the land. So yeah, so the need for improvement, we're going to try and keep it a little bit consistent, I think, throughout these showcases. So we're going to try to answer some of these questions that have been posed to us. And really for SALHN here, I guess it's the why. Why have we introduced the integrated management system? So as hospitals become more busy and complex, Sue O'Neill, our CEO, she talks about wicked problems. So wicked problems are those really big adaptive problems that people experience every day within healthcare, and often they're system-wide with no clear resolution or solution. And we really wanted to the question was posed around how could we empower our staff to fix problems at the local level or within their divisions, and how can we then provide a mechanism or an ability for them to escalate the problems they can't. So really that was the why and the rationale for the need for improvement. So this is a slide that I've taken out of our strategic directions map. And in the middle there is our operating principle, to listen, act, make better together. And 2 out of the 3 enabling strategies to be able to fulfill that is to build a continuous improvement culture and the integrated management system. And I'm just going to talk about those in a little bit more detail. I've just popped this in here too, and this is also from the strategic directions map. And really this talks about how do we build a continuous improvement culture here at SALHN. And it talks about going from the arrow down below here, from an ad hoc kind of approach to improvement. And really it's the step-by-step process that we need to take to be able to make sure that we're an exemplar, and that continuous improvement, it just becomes a way of life for every employee here at SALHN. So To allow this to happen, there's two key enabling programs. One is the Continuous Improvement Program, and the other is the Integrated Management System. The CIP, or the Continuous Improvement Program, has been running for the past 19 years or so here at SALHN, I think, Jane, and was revamped in 2019 with the commencement of CIP 001. It's based on continuous improvement methodology and follows an 8 steps to problem-solving process. And over this, since 2019, we've had over 200 problems that have worked through the continuous improvement program, and that's included over 400 staff. So that's one little component around how we build that continuous improvement culture here at SALHN. But the other one is the integrated management system, which is what I'm going to talk about today. So more than happy to touch base and talk about the continuous improvement program at another showcase. So the design and implementation. So this is around how do we connect our staff at a ward or unit level, you know, to every layer of the organisation, right? We talk about from ward to board, and then the flow-on effect of how then do we get from board to ward. So really the mechanisms of communication, really having clear, distinct ways that people can escalate through the organisation, but also to be able to communicate through the organisation. And so when we were looking at the design and implementation of the integrated management system, it was based on lean principles and making the work visible. Jane was here next to me, was integral in commencing. We started with tier 2. Tier 2 is our daily operational huddle, and that commenced on the 28th of August 2018. Now that's a daily operational huddle, really focuses on the flow element or the delivery element within the organisation, and I'll talk about that in a bit more detail shortly. And that's at the nursing director, allied health director, management, corporate leads, and executive level. And that's a touch point every day, 15-minute huddle, and it goes through the same kind of mechanism or matrix that we have at every level of the tiered system. Tier 3 is our weekly performance board huddle, and that's at the executive level, the divisional executive leads, managers and KPI owners. And that commenced on the 5th of September 2018. And it's a performance board huddle, again, around the 5 key domains. And I'll talk about the 5 domains in a moment. And really, it's around having a look at organisational-wide KPIs. Some are linked to our service level agreements, some are linked to those wicked type of problems or gaps we've got within current practice with the organisation. And so what you'll have is an executive sponsor, an improvement lead, and you'll have the clinicians or the clinical leads that will work through the methodology to work through those big problems. Tier 1, which is the daily ward unit huddle, is at all of the different wards or units that we have across the organisation. And that commenced as a joint partnership with PricewaterhouseCoopers back in January 2019. And so it was a joint initiative that we rolled out, I'll talk about that more in a moment, but that is a daily touch point every day, every single ward or unit. And since January 2019, we've been able to implement that in all of our acute areas here at SALHN, with the exception of the perioperative areas. And the perioperative areas are scheduled in for later in the year. So what happened is we had this tier 1, and then that feeds into our tier 2, which is our daily operational huddle, and that tier 2 feeds into our tier 3. But what we realised after we set up these tiers is that we missed a step. So we've introduced a tier 1.5, and that's at the divisional level. So what happens is that for all of those units that are within the division, so for example, the Division of Medicine, they all come together on a weekly basis and they have a look at their metrics and their KPIs, and they have a bit of a coordinated approach around how are they going, and is there a way that they can all be on the same page to measure or get to the target that they need around those divisional KPIs that they have there. And then we thought we had it sorted. We thought, yep, that's good. We've got the structure in place. And then accreditation came along, and we realised that we needed another tier. And these were around those organisational collaboratives where we kind of needed to bring everyone together on a common goal or a common purpose. So the things that we've used are tier 4, and these are a weekly meeting that bring all the divisions together. We use the tier 4 around those big organisational collaboratives. So we've used it for accreditation, the EMR implementation, various components around the national standards, and some of the other sustainability work that we've had throughout the organisation. So I've got a little quick video that I'm going to quickly share here, and it just gives you a bit of an overview of the integrated management system. So let me see if I can.
Hospitals have great people working in them, but often we work around really tough systems. The integrated management system is an approach that actually connects all parts of the organisation, what I call from the board to the ward.
So the integrated management system is our operational engine, and it's the mechanism for how we run our business. It connects the organisation at all levels, and it recognises that at a unit or department level is where the action happens, and that's where we really drive performance and impact on the patient experience.
The way we've organised that is around 5 particular areas or domains, we're calling them. The first is staff safety. The second is quality and experience of patient care. The third is delivery of our services. The fourth is about our great people. And the fifth is about cost or financial sustainability.
The foundation of the integrated management system is tiered huddles, and we have tiered huddles at all levels of the organisation.
At the huddle, we reflect on our performance and how we're tracking against our KPIs. We talk about our successes and recognise things that we're doing well. We talk about problem solving and issues that need resolving on the ward. We talk about planning, how prepared we are for today and how prepared we are for tomorrow, and we also talk about ward communication.
Tier 2 gives us the opportunity to hear about and know about what the issues are across the whole organisation and to mobilise our resources to help solve those problems on the day they arise.
For me, particularly coming to Tier 3, what I see is what's happening around the whole organisation. So it is better visibility across the organisation. I see what's happening in other divisions. I see how it affects our work, but how it's affecting other people at the same time in areas that I might not have been looking at or understanding at that time.
Through the rollout of the integrated management system, we've invested in our unit level managers to build their capability to manage their business and become mini CEOs of their units.
What the daily management system has helped me do is bring the staff together. We've got this open forum, we've got open discussion, and we're all able to engage with the vision. We've seen improvements across the board, which has just been really fantastic. But the thing I'm proudest of is that there are improvements not just in delivery, but also the quality of care that we're giving for our patients. We've seen 38% increase in use of the transit lounge, 72% increase in compliance with bedside handover, and a 5% reduction in length of stay, which are all massive. There's been a real cultural shift that we've seen. Staff feel heard, staff feel empowered to solve problems themselves, and I think really just take ownership of the ward and the work that they're doing. And I think that's really what's going to make it sustainable for us.
What we've been able to do is establish really clear lines of communication, and we've seen a better engagement from our workforce.
We've improved our staff engagement and our work within the multidisciplinary team by having all disciplines included in the daily huddle. We have had major improvements on our ward in terms of increasing our discharge numbers by 10 a.m. and implementing bedside handover across all 3 shifts.
When you come together as a team, I guess there's a shared vision of what we're trying to achieve. There's a process around that people understand what they're trying to do, what that team's looking at. They see how other groups are working in that same direction, and then they come back and re-look at it again on a day-to-day basis or a week-to-week basis intermittently, so that it's integrated. It's an integrated management system.
What's been fantastic at SALHN is the absolute connection with staff. I've seen people who felt disempowered previously actually being able to make different decisions, seeing what I call really tough problems that have been around for a long time solved. I've seen great connection between the executive, the management, the staff directly on the ground, across all of the different professional groups and clinical groups and non-clinical services as well. That's the most exciting thing about the integrated management system, is actually seeing people empowered, making decisions, solving problems, and actually feeling good about their work.
So the integrated management system works around our 5 key domains, and that's around, how do we listen, act, make better together. And so safety, as I said, is all around keeping our staff safe at work. It is the first domain for that reason, to really show that importance, that our staff are very important, and that is a priority for us here at SALHN. Quality is about safe and reliable patient care. Sometimes people put safety and quality together, but we've been really purposeful about separating the two of them and really clearly defining what does quality care look like for our patients. Delivery is around accessible and reliable systems, and that really relates to the flow and making sure that we have the right systems the right time every time. People is about staff being respected and fulfilled at work and having the tools to do that. And cost is about using our resources responsibly and transparently. We say we leave cost to the very last, because we say that if you fix the first 4, cost will sort itself. So on a lot of our visual management boards, we actually never have cost, because we say if we have safe staff, quality care, reliable and accessible systems, and people being fulfilled and happy at work, that cost will sort itself. And so that's the 5 domains that we have there. So this is a bit of a quick picture of our, it's actually not in this room anymore, but this is our tier 3, our pre-COVID, yes. We needed to move to a bigger room with COVID because of the social distancing requirements. But as you can see here, these are our key domains, and these are the KPIs that we're measuring under each of those domains. And what you will see here is there's a lot of crosses, which is good, because if we had a room full of ticks, it really means that we're really not stretching ourselves to be able to improve and to get to the next target. What you will see here is our NA3. And that's working through that continuous improvement methodology to be able to, work through understanding the root cause, understanding and breaking down the problem in greater detail, looking at your mission or your target, getting to your root causes before then you get to that intervention planning, and then you apply those PDSA cycles around it. So every single laminated sheet on here has a KPI owner that is following that improvement methodology to be able to work through, getting to where we need to be. So that's our weekly huddle that happens on a Wednesday at 10:30, and we always open for people to come and have a look at that huddle there. The next one is our tier 2 huddle, which is our daily operational type of huddle. Again, we firstly go through safety. Is there any safety issues for escalation or that we need to note? We go through inequality issues that required escalation from the tier 1 level. And then we go into the delivery. The tier 2 daily meeting that we have every day has a real strong focus on delivery and all things patient flow. So the first component is ED, talking around who's in the department, what's the breakdown, how long have they been waiting for, what are any of the blocks or barriers, do they have SAS capacity, do they not? And then we get into what is the plan then for each of those divisions. They talk about how many discharges they've had, how many they've got more that are potential, what have they got coming in, what haven't they been able to, and so we really talk about them. What are the blocks or barriers? Is there anything that we can do to be able to work together as a network to be able to get the patient to the right place at the right time. So that's that tier 2. It's online at the moment because the room that we were meeting in is still not COVID friendly. And so we will transition to getting back to a face-to-face. There's real value in all being together in a room. We say the huddle starts on time and finishes on time. So it's a 15-minute touch point, and we're able to get through all of that information really, really quickly. We also then talk about staffing, and so do we have the right staff? Is there any gaps? You know, what plans and so forth do we need to put in place? So the idea is that everyone knows the plan walking away from that huddle. And then we talk about the daily management system, or the tier 1 huddles, and these are at the ward or unit level. And there's some photos there of each of those daily huddles. And what you can see, I mean, the first area we've got here is the Jamie Larkham Centre, a mental health type area. The next one we've got there is endoscopy down at Noarlunga. And then the next one we've got here is one of our rehab wards, and so it has got a real strong, you know, rehab and aged care focus. So the way that the daily management system is made up of 10 elements. The key thing is it's not just a huddle. There's 10 elements that are rolled out over 12 weeks. And really, it's to be able to improve communication, build that capability within that ward or unit level to solve problems on a daily basis. And so we use the own, resolve, escalate type process. So they either own it. Yep. So, you know, you don't put a problem on the board unless you're willing to own it. It doesn't mean that you're necessarily going to fix it, but you're putting your hand up to say, yep, I'm going to own it and follow it up. It either can be resolved. There's a quick technical solution for it, and someone puts their name to follow that up, or it may need to be escalated. The other 10 elements I'll go through in just a moment, but really it's around bringing the team together to be able to plan ahead. Everything's visual. Let me just get rid of that. It's every board is focused around their vision. And so the vision unites the team behind a common goal. And what happens is we build, so we have the vision, and we go, so okay, your vision might be that you know, you want to provide safe patient care for pediatric patients. So what does that mean? So what we do is we build it down into a logic tree, so it can be broken down into practical steps. And so then we talk about what are the success factors, what do they look like, and then what are your key enablers, and then how does that then, you know, from your key enablers, what are the different things that we need to break that down to into specific KPIs that we can then measure on the board to be able to achieve our vision. And so that unites everyone around that common goal. They're also linked to the organisational vision as well. And so every board will have the domains are up there. So that's what the success factors look like: safety, quality, delivery, people. One other area that you might see there's an A or area specific on there. And then people work out then for their ward or unit, they're made together as a team. What are the key safety issues for our ward or unit? And so what do we need to measure? Where do we want to be? So you'll have a baseline. So B is for baseline. You'll have a T for target. And then the huddles occur each day of the week. And so the information's filled out. So that's a general outline of the daily management system. So the 10 elements, as I just said, we have 12 weeks of intensive training. We start with a 2-day boot camp for the ward or units, and then they'll have a weekly training element that's introduced that week, with the expectation that the element will be rolled out across the team for that week before they start the next element. So we start on vision, as I've just talked about. Visual management is to allow quick recognition of the information at a glance. So, you know, really quick look at the board. Are we on track? Are we not on track? Where do we need to be able to get there? We use colours, we use symbols, we use emojis. Emojis are very popular on our visual management boards. And so, you know, they make and shape and make the boards what they want. The huddles is a quick action-based focus meeting around the visual management board with a focus on reflection, recognition, and readiness. So we reflect, how did we go? We recognise what did we do well, where do we need to improve, and then we really focus on planning about what do we need to be ready for today's patients, and really we want to try and build maturity around getting ready for tomorrow's patients as well. The huddles I've just talked about, problem solving. So we really want to move the teams from firefighting every day around different issues to be able to go to understand what are the root causes, what are the real problems that they need to focus on, and to go to a bit of a proactive approach around problems and not a reactive approach around problems. So as part of the integrated management system, we lock in regular problem solving sessions with the team on a weekly basis, and they are worked around, problems around the ward. Standards is making sure that care is not one person dependent. So just because I'm coming today, Katie, because you're providing care to me, you're going to get a different level of care to somebody else. So it's around making sure we've got standards in place so that care is not one person dependent. Planning and control is about the ability to forecast and use PDSA cycles around the plans as well. So the how and why you do things, and really having that ability to be able to know your business and to be able to forecast and plan your business as well. Routines and practices, we challenge the status quo to really have a look at what is adding value within the activities that you're doing within your ward or unit environment. And if they're not adding value, are they potentially a waste, or could we be doing them slightly differently? Coaching and capability is about identifying skills and capabilities of our team members. So we work through a skills matrix and we look at, okay, so how do we get everyone from where do they sit within the novice to expert, and what do we need to do to be able to support them to develop those skills and to, really build that maturity of skills within the ward or unit environment. And then celebrating success, it's something we never ever do well. And even when we introduce this element, it feels clunky and it feels a bit forced, but it's really about recognizing team performance. And it's also about, providing that in the moment feedback so that it just doesn't become you're all doing a great job. It's really providing that, really a real great feedback that is person specific or team specific. Hey, you guys really came together and we had a tough day, recognizing that it was tough, but what I was really impressed with is that you're able to do this, this and this. So really being specific about the feedback that you're giving to the staff. And sustainability is how we're going to keep it going. And that's really one of the challenges that we're facing at the moment with the IMS. So this is a bit of a story around how does it impact our patients. So I just wanted to provide a specific example, and thanks Jane for reminding me of this issue that came up. So it was within our paediatric unit, and that's the other thing is that the huddles are attended by a multidisciplinary team. So we expect our medical staff, our nursing, midwifery, allied health, PSAs, ward clerks, everyone comes together. We say it's 15 minutes. You need to invest that time. And so what had happened is within our paediatric unit, the acute pain service, they introduced these little flip charts that kind of go on people's, where their key tags and so forth are. They introduced a new pain chart, and on there was some paediatric doses, and they noticed that they were incorrect. And this had been rolled out across all of SALHN, and it was quickly identified at the Tier 1 huddle as a really big problem. So they identified that it couldn't be resolved at the local level, and this was then escalated at Tier 2 that day, and the division that rolled out these charts were able to quickly get them pulled back and to have the new ones to be actioned immediately. So it really demonstrates the agility and the responsiveness that we have of the IMS to be able to get that quick communication out. Everyone knows what's going to happen, and that then at Tier 2 allowed for all of those charts to be retracted, and the new ones were able to be rolled out. I don't know how I'm going for time, so I'll quickly speed up a little bit. Through accreditation, it was a real driver for us to be able to reach a whole heap of targets that we needed to meet. And I'll give a specific example of that. What you can see there is this little chart that was made, a mandatory training chart. And this chart was placed on a tier 1 board, and it enabled everyone at the huddle to say, hi, we've got 5 people that still need to do the code of ethics. Is anyone here at the huddle one of those 5? And so Jane, if she was one of those people, she'd say, yep, I'm one of those 5. And what that required then is, Jane, you will do that ethics training in double staff time. And so that really was one of our key enablers to be able to focus on a target or a something that we were going to focus on for that week. And everyone came together. Yes, we're going to focus on this. We reached the target. Okay, what's the next thing we're going to focus on? The other thing as well is I was really impressed is that each of those comprehensive care standard leads for the ward environment would also give a quick update or a touch point around, this is what's happening with that standard, this is what's new, this is what you might need to know. And so they're really good at being able to get everybody on the same page. The other thing that I've just put there is one of the standards that was developed. This was from our Ward 5B around making sure that, what are the double staff time duties? And these were those little things that, the things weren't stopped and this didn't happen. And so really getting on the same page around, okay, so if you're on double staff time, the late shift, they would then come on and systematically tick through the box. And, it was just a way of making sure that we capture and do those things that needed to be done. The bushfires, it was, really great to be able to have a quick system when the bushfires hit, to be able to quickly identify the staff that were affected by the bushfires. Did it have an immediate impact on staff availability for each of those areas, and to put plans in place really, really quickly to wrap around and support that process as well. COVID-19 response, I'm sure we've all kept busy during this time, and we had to make and shape and stretch and adapt and all the rest of it. Yeah, so it's been able to be really, really good to be able to, we use the huddle boards, and we do have those quick touch point huddles, both within our COVID swabbing clinics, and also this is our vaccine clinic that you can see there, a quick huddle in the morning, talk about, how many doses have we got today? How was yesterday? How's everybody feeling? Is there any safety concerns? Is there anything that we need to do? Is there any problems, and working through those problems. I just kind of quickly show you on the top right here is our, when COVID hit, as with a lot of you, we had a short supply with PPE, specifically N95 masks. And as mask supply started to run out, like the auras and the halyard smalls and so forth, we set up the PPE team. And we prioritize those areas to be able to have, high risk areas to be able to have the N95 masks. But for the rest of the hospital, we couldn't we didn't have the stock to be able to have N95 masks on impress within every single ward or unit. And it was identified as a problem at tier 2, that what happens if we need to do basic life support? It's considered an aerosol generating procedure. We need to wear an N95 mask if we don't know, if they have COVID or they don't have COVID. And so what we were able to do is create these emergency N95 mask boxes. They have every single supply of all the N95 masks in there. They've got a tag, which then there's some scissors on the top that you just cut open, and that ensured then that if they needed to have any basic life support across the hospital, that staff had access to the mask that they were fit tested to, even if they didn't have it on impress. So that was another way that you can kind of see an issue that's been escalated from a tier 1 issue, and that's been able to be rolled out system wide. It's just a quick snapshot there of our PPE stock report, and that's really just demonstrating the use of colours. This went to every single tier 1 area every day during COVID to demonstrate our status of our critical stock, and then we were able to really be clear and transparent with our staff around the status of our stock, which really stopped that hoarding. People stopped then hoarding and hiding their PPE in cupboards, because we were able to provide an assuredness that we actually had PPE available. So our next steps, and I'm on the home stretch now. So we're doing a lot of work on the sustainability of the IMS at the moment. So we've got some areas of excellence where we've got that true multi-D huddle. We have, huddles occurring 7 days of the week. We've got different disciplines that will rotate and facilitate the huddle. And then we've got areas where, it's not to the quality that we want. And so we're doing some focus work around sustainability of the IMS across each of those areas. We do have the perioperative areas scheduled in for later on this year to roll out with the IMS. And then we want to continuously improve. So we're doing some work to really align our strategic planning to our, the KPIs that we measure within our Tier 1 boards. We should be within the deployed section here of the continuous improvement culture development plan. We like to say it's 2021, so we're kind of stretching out 2020 a little bit, and we're doing a bit of catch-up work because of the the little thing called COVID did get in the way a little bit of us doing what we needed to do in that area. And then we want to evaluate the program. So really see, is it still achieving our vision to be able to provide a mechanism for staff to be able to problem solve the problems they can, and then escalate the problems they can't, and really making sure that it's providing value to our employees, and it's still meeting the need that they have when we introduce the program. So that's a bit of a overall snapshot of the integrated management system. Yeah.
Fabulous. Thank you, Angie, and thank you, Jane. I'm sure that people that are on the call, particularly those that are sitting within South Australia's health system, there are a few outside actually, I think, by the look of it, but people that are sitting within South Australia would be able to reach out to you really easily, and we're happy to provide that connection through to you if people don't know where to find you. So thank you.
We're always happy for visitors.
Yeah, that'd be great.
If anyone wants to come and see the integrated management system,
yeah, and also invite you back perhaps once you've done some evaluation, and you can tell us sort of some of the impacts, particularly around flow or around other areas around safety and those other areas that you're having. Thank you.
We'd love to.
I just want to do, that'd be fabulous. So I just quickly want to flick back and offer an opportunity, I guess, to those that are on the call to speak to peers and colleagues, and I guess to look at opportunities perhaps to reach out and share your story. I think that the SALHN improvement team have set a pretty high bar today in terms of the content that they've provided us with, but that's absolutely not the expectation. Not that we're really glad you did it, but that absolutely, if someone's out there who's not got the capacity to produce a PowerPoint, for example, we're really happy to invite you to come and tell your story anyway. And so I guess really it is, have you succeeded in solving a problem, or have you not succeeded, right? Have you learned something whilst trying to solve a problem, and how can you have that opportunity to share that with your peers working in health? And really what we're looking for is to have some consistency to the way the stories are told, so that we can start to develop maybe some answers around how did I know I had a problem, and those sorts of questions. So that's absolutely what we're looking for. We're also really keen to hear from people about the themes that they might like us to explore. So flow was our first pick of the rank. May is still an opportunity. If anybody's got a suggestion for where we should go in May and the months ahead, and really just, anything's possible. So perhaps if anyone's got any ideas, please contact us through our website, ceih.sa.gov.au, and you can go to the contact us page and get in touch and let us know, or give us a ring if you know us. That's fine too. Thank you again to Angie and to Jane for joining Angie down at SALHN. Thank you to you all for joining us, and we look forward to seeing you next week at the same time. Have a great afternoon, everybody.